Thank you. Thank you, Beth. It's a great day on Mount Sinai. When you call up 42nd Street, that's their first greeting. It's a great day on Mount Sinai. How can I help you? And so I want to adapt that actually in Cath Lab. And so by next week, we will start saying that. It's a great day on Mount Sinai, and it's a great day today. Welcome to New York. I want to piggyback what Dr. Heck said because my topic is about the stress test and his is CTA. Mine will be very basic, but he mentioned in one of his slides that for a CTA, you have to be very careful if your creatinine is more than 1.5. And so if your patient is below 1.5 or even more than 1.5, then you will consider my stress test. So let's start. There you go. I have no disclosures. And mainly our objectives for this talk is to know the indication and contraindication of a stress test, to understand the different modalities, and overall to effectively select the optimal cardiac stress test for each patient. Now, whether you want to use, there are different ways to do a non-invasive and invasive way of assessing cardiac anatomy and function. For LV function, we commonly use echo. And for myocardial viability, we use SPECT MPI or the MRI. But for knowing what is the prognosis of our CAD and a diagnosis, and at the same time be able to fix it, we do cardiac cath. But prior to cardiac cath, we want to know what is the stress test. Usually, before you send our patients to us for cardiac cath, we want to know what is your stress test. And the aims of doing a stress test is mainly, of course, you want to know if there's a likelihood of a coronary artery disease. You want to estimate the prognosis, the extent of a CAD, if your patient already has a previous stent, or if there are any blockages or ISR that you want to know. You want to also estimate the functional capacity and if there are any abnormalities that you want to elicit that's present during at rest. So who are the people who needs a stress test? People in the cath lab, and I mind you, those who work in cardiac units, I guess every one of us 30 years and above must do a stress test, right? But then they should give us a discount, a 50% discount at least. So who are the people? Symptoms suggesting angina, acute chest pain, recent ACS after 3 months of conservative therapy and still refractory to your medications, patient having a known CAD and there's a sudden change in their clinical status. For example, in the history, you will ask them, have you had this, let's say, shortness of breath or chest pain for the past 3 months? Is it progressing? Is this something new to you? Prior coronary vascularization, such as a previous PCI or a bypass. Guidelines have shown that even if the patient is asymptomatic, you should do one stress test if patient had a bypass for the past, 2 years. And first 5 years, you still have to do one stress test, even if your patient is asymptomatic. Valvular heart disease, if your patients develop a new heart failure or cardiomyopathy, absolutely, you want to do a stress test before going for a cardiac cath if your patient is undergoing a non-urgent, non-cardiac surgery. What are the contraindications? Absolute contraindication will be unstable angina, or if your patient has an MI, or arrhythmias with hemodynamic instability, aortic dissection, and symptomatic AS. Relative contraindication will be symptomatic heart failure, pulmonary embolism, myocarditis, pericarditis. So what do we mean when we say classical anginal features? You should ask these questions, 3 of them, mainly. Is this triggered by emotional or physical stress? Does it last for 15 to 20 minutes? Is it relieved by rest or sublingual nitro? If you were able to say yes 2 or 3 out of these 3 questions, then you have a typical angina. You will say you have atypical angina if you only said yes to 1 of these 3, and it's non-cardiac if you said no to all of these 3. And so Pretest probability, this is important before you request for a stress test. Once you determine whether this is a non-anginal or atypical, we have to keep in mind that the pretest probability of ACS, this is according to the ACC-AHI guideline. So it's low probability of a CAD if it's less than 10%. You don't need no further testing. Intermediate probability between 10 to 90%, then you should request for a stress test. And of course, for more than 90%, definitely we should get a stress test. So as you can see, as you reach the age, as you grow older, 60s to 69, for women, they get an 86% probability this is a CAD. As compared to men, it's 94%. Younger age, for men having atypical chest pain, it's only 34%, but women, mind you, is only 12%. So it's kind of, for women, although typically we say, oh, I have a chest pain, but you tend to believe more, I don't want to be like, go leaning towards men, but they say women might think of it as not a chest pain, but it's something like emotional or like a work-related stress. So what are the stress testing without imaging? The more common one is the ETT, exercise treadmill test. And there are two components of this. Your EKG can be interpreted for ischemia, and your patient is able to do 4 METs. So what does it mean when you say 4 METs? Your patient can walk more than 4 blocks, and your patient is able to go up 2 flights of stairs without stopping. That's 4 METs. And so your patient can undergo exercise stress tests. What do you consider as an abnormal result? If you found ST segment depression, patient developed chest pain during the treadmill test, significant arrhythmia, and hypotension. So what are the imaging stress testing procedures? You have stress echo, your MPI, and your stress perfusion. You have to consider there are 2 components when you want to do a stress test: the stressing agent and imaging agent. When you say stressing agent, you have to choose, can the patient go for a treadmill? If the patient cannot do exercise, then you use the pharmacological material, either adobutamine or adenosine. Then you use an imaging. Do I want to do just a simple EKG, or would I want to echo? Or would I use a tracer, an isotope that could give me a better view, let's say a nuclear stress test? So let's look into the pros and the cons. For a treadmill, it's physiologic, it's simple, it's less expensive, it's good if your patient can walk. For dobutamine, you don't need an exercise. You just inject the dobutamine and your heart rate goes higher, and that's the treadmill part. But be cautious when your patient's having arrhythmia. Adenosine is also another medication that you can use that no need for an exercise, but you also have to be very careful in using this for patients having a COPD or asthma. EKG, definitely it's simple, it's less expensive, but it's not good to use if you have a baseline abnormality like a left bundle branch LBB or with ST changes. Echocardiogram. This is very good, but it's operator dependent. I will go for Samantha. She's very good. Samantha's here. She's the boss over here in the echo. But what are the challenges? Samantha will tell you if your patient has a poor window, poor resolution because the body habitus is huge, or the patient might have a breast implant. So that will be a challenge for them. Thallium or technetium, this is a tracer that you use for a nuclear stress test. I will explain to you more on the next slide. So when you use a stress echo, first you do it at rest. And then you put a stress material. Let's say you want to do a dobutamine, or you want to ask the patient to do the treadmill. You will compare the pre and the post with the following: contractility, the systolic function, volume, pressure gradient, filling pressures, pulmonary pressures, and the valvular function. As I mentioned earlier, it's a challenge if you have a body habitus that's huge and breast implants. Now let's go to the SPECT imaging. So initially, you will inject a Lexiscan or a dobutamine to stress the heart, to increase the heart rate. When you have no blockades, there's a good flow, it vasodilates, so there's a good flow of oxygen going into your heart. Now you inject a tracer so that you'll get a better picture of your imaging. If there's a blockades, it's dark, but if there's no blockades, it's light. So how do you select your modalities? First, you know your indication. Is it for diagnosis or prognosis, or just to localize ischemia? Next question is, can my patient do an exercise? If yes, then you go for your simple EKG stress or your treadmill stress test. But if not, then you have to use a pharmacological test with imaging. Lastly, take-home points. So I just want to emphasize that stress testing is indicated for patients with intermediate pretest probability, and that is between 10 to 90%. Each stress test has two components. You have an imaging modality and a stress modality. When determining which stress test to order, keep in mind their ability to exercise and whether any contraindications are present. Thank you.